2 as well. On day 2, Dr. Pradeep Paria will be the coordinator who will conduct the program. And yes, Pradeep, are you there?
Yes, sir, I am there.
Yes, so you please introduce Dr. Naveen and start the program.
Before that, I will request Professor Kalpana, the President of West Bengal Academy of Pediatrics, to welcome the new faculties today. Please.
Actually, I'm in the way. Sometimes the net is very poor, going high up. So very good evening to everyone, and welcome all of you in this second day of webinar. I welcome Dr. Naveen and Dr. Pradeep. Pradeep is there yesterday also. Dr. Sapan is there. Mayor is there. So the new one, Dr. Naveen Chidanand Swami. I welcome you all in this webinar. And as we already discussed that it is not only from the West Bengal, the faculties all over the India. It's a pan-India program and very successful program. And we are getting very much good and encouraging feedbacks from all. So now I hand over the platform to Dr. Shapan Kumar Roy as a chairperson, scientific chairperson. Please proceed this.
Yes, welcome. Now, Dr.
I may be excused. I may be out because of the net problem.
Sure.
Okay, thank you.
And best wishes for West Bengal and Kolkata. So, over to you, Pradeep. Please start the program.
Thank you, sir. Our first speaker is Dr. Naveen. He had done his MD in radiodiagnosis and DM in neuroradiology from PGI Chandigarh. He is now a consultant neuroimaging and interventional radiologist in sports multi-specialty hospital in Bengaluru. Dr. Naveen.
Shall I begin?
Yeah.
Yes.
Yeah.
Thanks, Dr. Pradeep, for the introduction. And good evening, everyone. Today, I'm going to talk the topic on MRI brain, overview on the sequences and the common anatomical landmarks of the brain. We'll build the talk. I will tell you first about the routine MRI sequences, which we do. Later, how we tailor to a pediatric patient. Then a disease-specific protocol based on the initial finding in an MRI scans, and how we can use the advanced sequences of MRI and assessment of myelination, which is very important in a pediatric patient. And finally, I will go through the common anatomical landmarks in the brain. Yeah. The routine MRI sequences. This is a T1 sequence, which better depicts the anatomy of the brain. How to recognize the T1 sequence? First, look at the CSF. It will be dark. White matter will be brighter compared to the gray matter. So you look at the CSF and the white matter. You know the sequence. Second, in T2, if you see the white matter, if you see the ventricles, the CSF will appear bright, and the extraaxial spaces, you look at it, it will appear bright. So it's a T2 sequence, and white matter will appear dark compared to the gray matter. Flare is nothing but the sequence same as the T2 sequence, except that the water content, that is the CSF, is suppressed in flare sequences. So rest of the signal intensity is similar to the T2. The other two important sequences which we use is the diffusion and SWI sequences. Diffusion weighted sequences, we will get diffusion sequences and ADC map, which is helpful in detecting the restricted diffusion. Restricted diffusion, in the sense, means there is a restriction of the movement of the water molecules. Can be seen in cytotoxic edema, such as an infarct, where the ATP levels will be low due to decreased blood supply. So water molecules across the cell membrane will be restricted. So it will appear as a restricted diffusion. In cases of a tumor, due to increased cell count and cell membranes, there is a restriction of water movement. Restricted diffusion.
Oh.
Excuse me,
Dr. Kostov Naik.
Somnath, please mute all, except the speaker.
Hello?
Please continue, Dr. Naveen. Please.
Can I continue?
Yes.
Yeah, yeah. You continue.
And the SWI sequence. This susceptibility weighted imaging helps us to detect the hemorrhage, that is the blood products, and calcification in the brain. These are the routine sequences of an MRI brain protocol. Next. Flare sequence is not much useful in children because of the high water content. It has a triphasic wave pattern where the white matter can appear initially hypointense, then hyperintense, then again hypointense. So flare is relatively useless in children. This is the diffusion sequence. We can see how a restricted diffusion will appear as a bright signal on DWA sequence. This is the SWA sequence. It appears as a dark signal. That means it's a blood product. Here in the medial globus pallidus, we can see a dark signal, but it is not a blood product. To recognize this, we have to look into the phase images. In phase images, these blood vessels are looking dark, but this lesion is looking bright. So it is opposite that of the blood product. So it's a calcification. Apart from that, we routinely do volumetric sequences. The benefit of volumetric sequences is we can do multiplanar imaging. Here we can see the axial, coronal, and sagittal images and reformat it and see the lesion, exactly lesion. And even in regular sequences, we can able to miss the small lesions because we take a 5 mm thickness. Here, it is a very small, thin thickness volumetric sequence, which can be reformatted in any plane which we want. So and sagittal planes are used to look at the midline structures such as the cella, pituitary, corpus callosum, and all. And the coronal images can be used to look at the optic nerves, paranasal sinuses, cavernous sinuses. The difference between the pediatric protocol and adult protocol is the slice thickness which we use in pediatric patient is 4 mm and compared to the 5 mm thickness in adult, but we use a short FOV. The brain sequences in various diseases can be, we can organize it as a protocol. So it's very easy for the technicians to do the scans. Whenever we find a whenever we have a finding on the basic MRI sequence, we can tailor it depending upon the pathology. As the repeating the sequence means the child has to be sedated or has to undergo general anesthesia. So which will be cumbersome and as well as time consuming. For infection protocol, I will explain you with an example how we can alter the sequences to make a diagnosis. Here, this is the routine flare T2 and T1 post-contrast sequences. Here, we cannot see any pathology. This is the gradient imaging post-contrast where meningeal enhancement is not so good. So in these cases, whenever we think of an infection, we always do T1 spin echo post-contrast, which is very sensitive to meningeal enhancement. Anyone could make out this meningeal leptomeningeal enhancement in this. This is initially you can see until this CSF is bright. This is a T2 sequence. No, it's not. It's a post-contrast flare, 3D flare. I will show you. See, this is the 3D flare sequence. Here CSF is suppressed. This is a flare sequence. Then how come this CSF is bright here? This is an exudative CSF in case of a meningitis, where we can see this meningeal enhancement. So post-contrast 3D flare we can add to improve our sensitivity in case of meningitis. In case of ring enhancing lesion, we can use make use of many sequences like diffusion, susceptibility, spectroscopy, perfusion to differentiate between the abscess, tuberculomas, NCCs. NCC lesion is very small, so we can use the high definition, very thin sequences, CIS sequence, which can detect the spolix, which is usually not seen in the routine sequences because of the thick sections. And MR spectroscopy and MR perfusion, these are all the functional studies, which also helps to differentiate between the neoplastic and non-neoplastic. Since MR perfusion can able to detect the angiogenesis, and spectroscopy is used to detect the metabolite. So in this way, we can differentiate between the neoplastic and non-neoplastic. Tumor protocol. We usually do a basic sequences with contrast. Apart from that, children with brain tumor should always be imaged for spine, because the medulloblastoma and ependymoma are known to cause CSF metastasis, drop metastasis in the spine. So post-contrast T1 whole screening of spine is must. And volumetric sequences are usually included in tumor protocol because it will help in neuronavigation guided surgeries for the neurosurgeons. This is a medulloblastoma case. We can see the nodular enhancing lesion on the posterior part of the leptomeningeus, suggestive of leptomeningeal metastasis. Other advanced imaging, which are the functional imaging, which can be used, which are used in tumor protocol, is the perfusion imaging. It can be done with a contrast as well as non-contrast. Perfusion mainly detects the angiogenesis. In case of a high-grade tumor, we will see more perfusion. In MR spectroscopy, we can detect the metabolites. Means to say, in tumor, if there is because of increased cell count, there will be increasing coilin, which is a component of a cell membrane. Whereas due to destruction of the brain, there is decrease in NAA, which is the component of brain. So by studying the metabolite, we can exactly make out whether it's a tumor or it's a high grade or a low grade. Diffusion tensor imaging is mainly helpful for the neurosurgeons to see the effect of tumor on the white matter tracts, whether there is a displacement, whether there is an involvement of the white matter tract, and also mainly helps in planning surgeries. And in post-op patient who has received radiation, this functional imaging will help in differentiate between the tumor recurrence as well as radiation necrosis. As in basic contrast imaging, both will enhance. So we have to do the functional imaging. This is an example. We can see a left frontal lesion. It's a glioma. We can see the restricted diffusion because of high cellular content. On SWA, we can see the hemorrhagic products. This is the post-contrast T1 sequence, which we can see the heterogeneous enhancement. This is the perfusion study. We can see the increased perfusion parameters within the lesion because of angiogenesis. This is the MR spectroscopy. We have taken a sample from the tumor. Small box is the sample. Here we can see the metabolite coilin peak, which is a component of a cell membrane which is increased, and NAA peak, which is decreased because of destruction of the brain parenchyma. This is the DTI sequence. We can see tracts, various white matter tracts, which has undergone displacement here. So this will help the neurosurgeon in planning the surgery. Functional MRI is helpful in counseling the patient as well as knowing the prognosis, and also it helps for the neurosurgeon preserving the important areas, functional areas. Here we can see a paracentral glioma in the paracentral region. This high signal which we see in the left temporal lobe is the Wernicke's, that is the language area. So it helps in language lateralization. So we can able to tell which lobe is dominant based on this functional MRI, which helps in planning surgery. This is the motor cortex. If you do a motor function during the MRI, this signal will be picked up on the primary motor cortex. So we can see the lesion relation with the motor cortex. And in the follow-up of this tumor patient, usually post-surgically, the MRI can be done within 72 hours or after 3 months, because after 72 hours, there will be a reactive enhancement because of the post-op changes, and we cannot able to tell whether it's due to a residual left-out lesion or due to a post-operative enhancement. So usually it is recommended in any medulloblastoma or epithelioma, any tumor case, to do a repeat scan after 3 months. Epilepsy protocol. In epilepsy protocol, apart from the routine sequences, what we use is the coronal thin sections, which is perpendicular to the hippocampus, which is very 3 mm sequences, and volumetric sequences of T1 is the routinely used because small lesions like FCDs and cortical malformations can be detected because of the better gray matter and white matter differentiation. This is the volumetric sequence. It can be reformatted in multiple planes. Here we can see the thickening of the cortex in the right paracentral lobule region. Compared to this, here we can see, we can make out the gray white matter differentiation. Here it is obscured. So these volumetric sequences will help in detecting these FCDs and heterotopias and cortical malformations. And another thing is coronal T2, as I told. It's a thin coronal sequence which is taken perpendicular to the hippocampus. Here, right hippocampus, we can see the altered signal intensity, that is hyper intense. There is loss of digitation, volume loss in the form of prominent temporal horn. This is a case of hippocampus sclerosis. Here, this is an ASL perfusion. We can see the decreased perfusion in the right hippocampus compared to the left. This is a more advanced study, that is the T2 relaxometry. This is helpful in cases where there is a bilateral mesial temporal sclerosis and we don't have any baseline to compare the signal intensity. So it will give you the quantitative value rather than eyeballing. So case of bilateral temporal sclerosis, T2 relaxometry will be helpful. And epilepsy protocol is usually recommended to do in 3 Tesla because of the high spatial resolution. And functional MRI can be done for pre-surgical evaluation of the language lateralization and sensimotor cortex. Other advanced studies which we can do is the PET and SPECT scan, which help to detect the seizure focus. demyelination protocol. Demyelination disease like such as MS, NMO, or ADAM. In these patients, always you should screen for orbits and spine because it helps to differentiate the pattern of the demyelinating diseases based on this, because demyelination diseases usually associated with optic neuritis and myelitis. This is the T2 fat set sequence. Here we can see the hyperintense T2 optic nerve. Here there is a post-contrast enhancement of the optic nerve. This is a case of optic neuritis. And here in the T2 sagittal screening of the spine, we can see multiple hyper demyelinating lesions in the cord. So in all demyelinating protocol, we should screen for the orbit as well as the spinal cord. In various metabolic diseases and lipodystrophy, apart from doing the basic protocol of the brain, you should include the MR spectroscopy of the lesion in the white matter. In Canavan's disease, we can see an characteristic NAA peak. In case of mitochondrial disease, because of anaerobic glycolysis and decreased mitochondrial dysfunction, there will be elevated lactic peak. Here we can see the elevated lactic peak, which is inverted at intermediate T. In case of hydrocephalus, we do high resolution sequences, very thin sequences to look for any communicating or obstructive hydrocephalus. In case of previous hemorrhage, which is causing the hydrocephalus, it can be seen in SWA. Contrast MRI can be done to rule out infective cause of communicating hydrocephalus. CSF flow study can also be done in cases of Chiari malformations and in case of to see the communication with the arachnoid cysts and shunt malfunction. See, this is the 3D sequence, which is a very thin high resolution sequence. Here we can see an aqueductal web, which is the cause of this hydrocephalus. This is the dilated third ventricle and bilateral lateral ventricle resulting in congenital hydrocephalus. This is the CSF flow study. Here we can see the normal flow of CSF anterior to the spinal cord. In the posterior to the cord, CSF flow is not so good because there is a Chiari malformation with crowding of at the base of the foramen magnum. So decompression of the surgery should be done in such cases. Apart from that, you should know about how to assess the myelination in a child. Rapid changes will take place in the child's brain up to 2 years of age. Because of the growing myelination, there will be decrease in brain motor content, which is the cause for this signal changes in the MRI. In the first 6 months, T1 weighted imaging is the best sequence to assess myelination. And the myelinated white matter tags will appear bright on T1 because it's a fat. Myelin is a fat and it appears bright. In T2 and after 6 months, up to 2 years, T2 is the best for myelination because T2 mainly detects water, and as the myelination goes on, water content of the white matter decreases and T2 white matter tags will appear dark. What are the basic principles we should remember to assess myelination is the signal changes of myelination appears early in T1 compared to the T2. So in first 6 months, we usually look at T1 and later T2. This is the direction of the myelination. Myelination begins in the caudal part of the brain and it extends to the cranial part of the brain. And it begins from the posterior part of the brain and goes to the anterior part of the brain. It begins from the central part of the brain and goes to the peripheral part of the brain. In a term infant at birth, we should know always whether the infant is term or preterm, and it's calculated according to the gestational age. Myelination should be always correlated with the gestational age. This one, we can see the term baby. This is the posterior part of the brainstem is myelinated. It's appearing bright on T1. And posterior limb of the internal capsule is myelinated. It is appear bright, and anterior limb is dark. VPL, ventroposterior nucleus of thalamus is bright, which is myelinated. And this perirolandic region will appear myelinated in a newborn, and the optic tracts. These are the normal myelinated structures at birth. The same can be seen in T2, which appears dark. At 3 months of age, if you assess, see the dorsal part of the brain was myelinated at term. Now the entire brain, even the ventral part of the brainstem is myelinated. Here, the anterior limb of the internal capsule is also myelinated. And posterior most part of the corpus callosum, that is the splenium, is just started myelinating, and the central part of the centrum semiovale is myelinated at 3 months of age. So when compared to T2, it lags behind. We can see here anterior limb of intercapsule is myelinated in T1, whereas in T2, only the posterior limb is myelinated. And again, the splenium is myelinated in T1. Here, splenium is unmyelinated. Still, it looks bright. So at 6 months of age, if you look at this, the entire corpus callosum, including the genu, is myelinated. And most of the white matter, that is parieto-occipital white matter, and part of the frontal white matter is myelinated. In T2, now the ventral part of the brain is myelinated, and anterior limb of the intercapsule is now start myelinating. At 12 months, usually the T1 resembles that of an adult. Entire brain is myelinated except the subcortical fibers in the anterior frontal lobe and temporal lobe. So it's almost looks like an adult brain at 1 year of age. In T2, see this T2, almost the MRI brain of a child appears like an adult. Here we can see the entire white matter is myelinated on T1, and T2, so almost entire brain is myelinated except the subcortical U fibers in the anterior part of the temporal lobe and frontal lobe. And we should also remember a normal variant while interpreting. What is this? There is a bright signal which can be seen in the peri-trigonal region. This can be a normal. This is the terminal most zone of the myelination. That means it myelinates at the last. How to differentiate with the most common pathology, that is the periventricular leukomalacia in children? Just look at the ventricular margins. If there is a white matter, hypointense white matter tag, that means this is a terminal zone of myelination. In case of periventricular leukomalacia, the bright signal will be immediately adjacent to the ventricular margin. I'm going through the brief. I will brief about the normal brain anatomical landmarks. The brain cerebral hemisphere is divided into 4 lobes: the frontal, parietal, occipital, and temporal lobe. The another 5th lobe is the hidden, that is the insular lobe. And how to divide this lobe? You should know that these landmarks to divide this lobe. That is the central sulcus, which separates the frontal lobe from the parietal lobe. The lateral fissure, which is the deepest sulcus on the lateral surface of the brain, it separates the frontal and the parietal lobe from the temporal lobe. The parieto-occipital sulcus separates the parietal lobe from the occipital lobe, and the pre-occipital notch, which separates the occipital lobe from the temporal lobe. So, how to make out this in an MRI? First, identify the central sulcus, identify the lateral fissure, identify parieto-occipital sulcus, then you will be able to identify all the lobes. So this is the central sulcus, which is separating the frontal lobe from the parietal lobe. That is the motor area from the sensory area. This is the deepest sulcus, which reaches up to the medial surface of the brain. So one way is to make out it's the deepest sulcus. There are around 10 sites in MRI to detect about the central sulcus. This is the L sign, that is the superior frontal gyrus. This is the precentral gyrus. It forms a L shape. Just posterior to it is the central sulcus. T sign. This is the superior frontal sulcus and the precentral sulcus. They intersect at the T junction. So it's a T sign. Posterior to this is the central sulcus. Knob sign. It looks like a door knob. Here we can see this is the motor hand area that is in the precentral gyrus, which looks like a hand knob. It looks like a hand knob. So this is the premotor area. This is the central sulcus. This is the sensory area, sensory cortex. And another thing is the precentral gyrus will be very thick because of high motor cortex, high neurons in the motor cortex, compared to the postcentral gyrus, which is very thin, which is a sensory cortex. So in between is the central sulcus. So once we made out the central sulcus, then the most common consistent landmark on the lateral surface of the brain is the lateral sulcus. This is the various ramification of the lateral sulcus. I'm not going to go through deep about this. This mainly helps in separating this frontal lobe or parietal lobe from the temporal lobe. And the deepest sulcus, which is seen about 5 centimeters posterior to the occipital pole on the medial surface, is the parieto-occipital sulcus. These separates the parietal lobe from the occipital lobe. Then going to the frontal anatomy, frontal lobe anatomy. Mainly in the frontal lobe, there are 3 sulci, which divides the brain into 4 gyrus. This is the superior frontal sulcus, inferior frontal sulcus. So it divides the frontal lobe into superior frontal gyrus, middle frontal gyrus, and inferior frontal gyrus. This is the precentral sulcus. Anterior to this is the precentral gyrus. This is the superior frontal gyrus, middle frontal gyrus, inferior frontal gyrus, and these are the superior and inferior sulcus which are dividing it. This is the precentral sulcus, this is the central sulcus. So between this is the precentral gyrus, that is the motor cortex. And the motor cortex, so this is the homunculus representation. The medial part of the brain represents the leg function, and whereas as you go laterally, you will see the hand function and functions of the face muscles. Inferior frontal gyrus is again this area will have the Broca's area, that is in the exactly in the pars triangularis. Medial surface of the frontal lobe, just above the corpus callosum, you can see the cingulate gyrus, and just above it is the superior frontal gyrus, and this is the paracentral lobule, which are the part of the frontal lobe. This is the central sulcus. This paracentral lobule include both the motor as well as the sensory area. Coming to the parietal lobe, there are mainly 2 sulci in the parietal lobe, that is the posterior central sulcus and interparietal sulcus. And gyrus are the posterior central gyrus, and interparietal sulcus divides the parietal lobe into superior parietal lobule and inferior parietal lobe. Inferior parietal lobule is again divided into superior marginal gyrus and angular gyrus, which connects the Broca to the Wernicke's area. This lesion in this region can cause aphasia. No, this is the medial surface of the parietal lobe. Medial surface of the parietal lobe will have the paracentral lobule and posteriorly the precuneus, just anterior to the parieto-occipital sulcus. Then going to the lateral surface of the occipital lobe. The lateral occipital sulcus, the deepest sulcus on the lateral surface of the occipital lobe, divides it into superior occipital gyrus and inferior occipital gyrus. Medially, the occipital lobe is divided into lingular gyrus and the fusiform gyrus. And posterior part, and again the medial surface, there is a deep calcarine fissure. Below this, above this is the cuneus. Temporal lobe. Temporal lobe is divided by superior and inferior temporal sulcus into superior, middle, and inferior temporal gyrus on the lateral surface. On the medial surface, you can see the hippocampus. This one is the parahippocampal gyrus. Moving from the gyral anatomy to the diencephalon, this is the caudate nucleus, septum pellucidum. This is the lentiform nucleus, which is outer divided into putamen, medially into globus pallidus. This is thalamus. The hypointous white matter tract, which you can see, this is the anterior limb of internal capsule. This is posterior limb of internal capsule. This is the genu of the corpus callosum. This is the splenium of the corpus callosum. Moving to the brainstem, the infratentorial part. These are the sections from the lower, from the midbrain. These are sections from the pons, and these are the sections from the midbrain. Going to the midbrain, medulla structure at the level of medulla. This is the 4th ventricle. This is the 7th and 8th nerve complexes. We can see at the pontomedullary junctions. This is the medulla, and this is the cerebellopontine angle, perimedullary systems, and this is CP angle system. This is at the level of the pons. This is the pons. This is the cerebellar, middle cerebral peduncle, which connects with the cerebellar hemisphere. The middle one is the cerebellar vermis, and on both sides is the cerebellar hemisphere. This is at the level of the midbrain. This is the
Sorry to interrupt you, Dr. Naveen. You have 3 minutes more. Okay.
Okay. Just one slide.
Yeah.
Okay. This is at the level of the midbrain. These are all cerebral peduncle. The posterior part we will have a cerebral aqueduct and the tectum. This is the ambient system, quadrigeminal system, interpeduncular system. Anterior to it, you will see the cellular structures. So in conclusion, apart from the routine conventional imaging, though it is sufficient to arrive at the diagnosis, many of the time, based on the findings, we have to tailor it and add additional sequences. Advanced, we should make use of an advanced neuroimaging sequences like perfusion spectroscopy and functional MRI, which adds to the value. And you should have a basic understanding about the myelination milestones, which helps in understanding the pediatric myelination disorders. While considering myelination, we should also remember that to say it's as a hypomyelination, minimum you need 2 MRI done 6 months apart. If it's the first MRI, if you see that myelination is not sufficient, you should repeat after 6 months to call out it as a hypomyelination disorder. And the pediatricians, they should be aware of whenever giving a requisition about, they should specifically mention for what it is being done, and they should know about at least mention it as a infection or tumor, and discuss with the radiologist before doing a scan, as the most of the pediatric patient needs a sedation and GA, so we can save time and prevent from repeating the scan. Thank you.
Thank you, Dr. Naveen, for this excellent presentation. This is making this topic easier for our residents and our delegates. Initial part, some of the participants has mentioned that it was very fast. So, and one or two them asked of what is DWI sequence. Can you go to the first 1-2 slides and just explain the initial basic sequences?
Okay. This one, this is the routine 5 sequences which we do. This is the T1 sequence. You want to know how to make out this sequence? I will repeat it again if they want. This T1 sequence, you should look at the CSF. It will appear dark, whereas the white matter will appear bright on T1 compared to the gray matter. If you look at the T2, T2 is very sensitive to water, so it will appear bright. So CSF will be bright on T2. Whereas myelination, myelinated white matter will appear dark compared to that of the gray matter. Flare is same as the T2 sequence. Only thing is that the CSF will be suppressed in flare sequence because of double inversion recovery pulse. The CSF will be suppressed. So we can better make out the periventricular region because CSF what is suppressed, and we can also make out this exudates because the CSF is suppressed at the cortical surface. Diffusion weighted sequence, as I told, it will detect the water molecules movement. So whenever there is a restricted movement of the water molecules, such as in case of a cytotoxic edema, in case of an infarct. In case of an infarct, there will be decreased blood supply, decreased ATPs. So the water molecule movement across the membranes will not happen because there will be no energy ATPs. So the diffusion will appear as a bright. In cases of a tumor, because of an increased cellular count, the cell membrane will be more. So again, there is the restriction of water molecules. So restriction diffusion. Restriction diffusion can also happen due to high proteinaceous contents because of macromolecules, which has decreased movements. This is the SWI weighted sequence. That means susceptibility weighted imaging. It helps in detection of blood products and calcification. Blood products and calcification will appear dark on SWI. To differentiate between them, we have to look at the phase filter image, and you should compare with the blood vessels. If it's the same as that of the blood vessels, then means if it's dark here, then it's blood. If it is white, that is different from that of the blood vessel, then it's calcification. So this is the basic MRI sequences.
Thank you. So one of the participants has asked about the CISS and the Fiesta sequence. Is it possible to do?
Fiesta sequence is from Siemens, and Fiesta is from GE machine. Both are same sequence. It's a high resolution thin sequence, T2 heavily T2 weighted sequence.
Thank you. Thank you, Dr. Naveen. I think there is no such any other questions, and we'll move to the. You can please stop your slide sharing. We'll move to the next session. Okay. So for the next session, it is my privilege to welcome Dr. Arushi Saini, who is Associate Professor and Consultant of Pediatric Neurologist attached to Pediatric Neurology Unit of Advanced Pediatric Center, PGIM at Chandigarh. She has several publications in national and international journals and the chapters in the books. She was the proud recipient of the prestigious Bernard D'Souza Fellowship Award, and her primary area of interest are the neurometabolic disorders. So Dr. Arushi Saini will be talking on the overview of neurometabolic and degenerative disorders on MRI brain. I think she will be the fittest person to talk on that topic. Over to you, Dr. Arushi.
Thank you, Dr. Meher. I am audible?
Yes, yes.
Okay, I'll start sharing my screen then.
Yes, it is visible.
Okay, thank you. So good evening, everyone. Thank you, the organizing team of West Bengal IAP for organizing this session. And I am a clinician, so I've been allotted this rather difficult topic about overview of metabolic and degenerative disorders on MRI. So I'll be primarily talking about these from a clinician's perspective, and I'm very glad that Dr. Naveen has just concluded his session. So he has given us a good insight into the technical aspects of MRI. So I'll be just discussing about the clues. Now, I believe that if you have to understand the imaging of neurometabolic or neurodegenerative disorders, you also need to have a broad understanding of what type of disorders are you dealing with. And the role of neuroimaging is primarily for a clinician is in the form of pattern recognition and identifying the neuroimaging clues towards the diagnosis. So I would like to still begin with the definition of neurometabolic disorders. So IEMs, we all know, are it's a broad heterogeneous group of disorders where single gene defects cause a block in a metabolic pathway. This is generally in the form of an deficiency of an enzyme or a cofactor or a transporter, which results in either an accumulation of a substrate behind the block or deficiency of the product ahead of the block. Now, why we deal with neurometabolic disorders separately? Because brain is involved in almost 60 to 80% cases of all IEMs. Hence, neurometabolic disorders concern the clinicians a lot. And the majority of these disorders are autosomal recessive in inheritance. Now, this is just a broad and a simplified classification. So if you have to look at the overall inborn errors of metabolism, you could broadly divide them into these three categories. The larger one would be the disorders of intermediary metabolism. A second category is disorders which involve the energy metabolism. And the third category would be complex molecule disorders. Now, the disorders of intermediary metabolism and those that involve the energy are often clubbed together as small molecule disorders. This is because they concern the metabolism of smaller, simple molecules like carbohydrates, proteins, lipids, nucleic acids, vitamins, and minerals. The complex molecule disorders are also sometimes called as large molecule disorders because these are complex molecules which are often the combination of several compounds together. So if you remember some of the examples, you would remember these disorders. So the classic example of disorders of intermediary metabolism would be either your amino acidopathies like maple syrup urine disease or phenylketonuria. The second category would be organic acidemias like methylmalonic acidemia or propionic acidemia. Then the urea cycle defects also fall into the disorders of intermediary metabolism, and disorders of carbohydrate intolerance also come here. Now, disorders involving the energy metabolism would obviously be the disorders where the molecules which supply energy in the body are affected. So for ease to remember, we got the energy from either carbohydrates, fatty acids, or the mitochondria, which are in fact the powerhouse of the cell. So the disorders which involve their metabolism are often clubbed into the second category. And the complex molecular disorders, the typical example would be the storage disorder, whether they concern the lysosomal storage or peroxisomal disorders, or if they're congenital disorders of glycosylation, or they pertain to cholesterol synthesis. So with this background, so the classifications of these disorders are rapidly changing and evolving. So we now have more than 1,500 disorders, and every year a new classification is coming. But I think for practical purposes, the classification, the three categories are important for us to understand. So I'll just give you a brief about what to expect when you are thinking of a particular disorder. Now, disorders of intermediary metabolism, they commonly lead to intoxication or deficiency of a substrate. So you can imagine when there's a block in these metabolic disorders, so the neurological symptoms will be because of either an acute or progressive intoxication from the accumulation of a toxic compound. So the typical example would be like phenylketonuria or MSUD, or among the organic acidemias. We've just discussed these examples. Now, the disorders of metal intoxications, the porphyrias and neurotransmitter disorders are also put in the recent classifications in the same category. Now, what is the clinical implication? Now, because these are small molecules, they mimic several neonatal and pediatric illnesses. They do not generally interfere with the embryo-fetal development, because when the fetus is inside the maternal body, the maternal circulation is rather taking care of the metabolism. So usually there is a symptom-free interval after birth because the metabolite takes some time to build up in the body of a newborn. And in the acute state, they commonly present with vomiting, coma, organ failure, or thromboembolic episodes. And in the chronic state, they often come to our outpatient clinics with developmental delays, failure to thrive, or other neurological manifestations. Now, these disorders are often precipitated by typical triggers, and their diagnosis is relatively easy by metabolic testing, and the treatment is basically based on removal of the toxin by several mechanisms. Now, the second category was disorders involving energy metabolism. So their symptoms obviously would be because of the deficiency of in the production of energy in the body, or they could be either these could be generalized symptoms, or they could be localized to specific organs like liver, heart muscles, or the skeletal muscles, or the brain. So broadly, there are two sites of defects. The one is the mitochondria, which deals with mitochondrial disorders as well as fatty acid oxidation disorders. And the other site of defect is the cytoplasm, where the glycogen metabolism occurs. Again, what is the clinical relevance? The clinical relevance is that since these are energy deficiency disorders, they would come with symptoms of hypoglycemia, elevated lactates, or if there are organ-specific involvement, then there'll be enlargement of these organs. They will also come with failure to thrive or specific organ failures. Now, their diagnosis is relatively difficult because you will have functional tests for them, but you can't easily diagnose them on the basic metabolic screens. You could do the enzyme analysis or the specific function test, or you will have to resort to molecular diagnosis. The treatment in the acute state is replace, we try and replace the energy. Now, disorders involving complex molecules, you should remember that we're talking about storage disorders. So they involve storage in different cellular organelles. Because of this storage, they have often characteristic facies or appearance. So the typical storage disorders would look like this. Because the storage also happens in the bone, so they have typical changes which are called as dysostosis multiplex. I'm sure they have been dealt with already. And there is evidence of storage in other organs as well. So for example, if there's storage in the retina, you see a cherry red spot. If there's storage in the bones, you see bone changes, you see organomegaly because of that, or you could see megalencephaly because of the brain storage. What are the clinical implications again? The symptoms of these disorders would be often permanent and progressive. There would hardly be any intercurrent events which would lead to sudden triggering. They would be unrelated to the diet, and their diagnosis is difficult. You have to resort to specific and targeted testing. There is no acute treatment, and enzyme replacement therapy is available for some of these disorders. So with this broad idea about the classification of disorders, also remember that the common presentations in the neonates of neurometabolic disorders are that, so if you imagine a newborn infant where you suspect a neurometabolic disorder, the common presentation would be an encephalopathy. It can be without metabolic acidosis, it can be with metabolic acidosis, or it can be with respiratory alkalosis, or there can be a presentation of isolated neonatal seizures. So this is what concerns the brain. Now, in an older child, the presentation is a little more varied. So you can have an acute encephalopathy like a neonate, which can be with or without other metabolic abnormalities. And there can be an overall neurological syndrome. So for example, they can come with any neurological symptom. They can come with a chronic encephalopathy or dementia or developmental delay. They can come primarily with epilepsy. They can come primarily with stroke or movement disorder or muscle involvement or psychiatric presentations or other tone changes. And they can sometimes have a combination of several of these presentations. So with this background, I want to stress here that in the diagnosis of neurometabolic disorder, the physician is the most important person. But the diagnosis is ultimately made from a combination of physical features, biochemical, imaging features, and often the genetic features. So keep in mind that no one investigation probably can give you a clue towards a specific diagnosis. Often you have to interpret all of them together. Now, I'll try to highlight this point with the help of this case, because this is primarily because I want to keep the presentation still clinical and then take you towards neuroimaging, which has been allotted to me. So how is a typical presentation? So we have this 8-month-old girl who was previously developmentally normal, and she presented with encephalopathy, which followed a fever. So looking at the last 12 days of her course of illness, she initially had a low-grade fever for 2 days. Then she became afebrile. However, by day 5, day 6, she started having poor feeding and lethargy and gradually started showing neuroregression. So she lost head control. She was unable to sit without support. And then she started developing fast breathing and worsening sensorium. And finally, she was taken to a hospital where she required intubation because of progressive encephalopathy and was ultimately referred to us. There was no history of any focal motor deficit, abnormal odor from the body or skin rash, abnormal skin or hair pigmentation, vomiting, loose stools, any movement disorder, seizures, or eye abnormalities. This is the 3-generation family tree, which was not contributory, and her past history had been eventful. On examination in the emergency room, she had worsening tachypnea, or we could say mild tachypnea with acidotic breathing. Her head circumference was normal. And on the detailed examination, her sensorium was depressed. She hardly had any more spontaneous motor activity. There was minimal response to pain. She had generalized hypotonia with brisk reflexes, which we call as central hypotonia. She had a palpable liver, which was 2 centimeter palpable below the right costal margin. However, the surface was smooth. So looking at the database, this 8-month-old girl with the febrile illness leading to progressive alteration in sensorium and regression of milestones and presentation with acidotic breathing, encephalopathy, hypotonia, and brisk reflexes, the normal head circumference and fundus. So if you have to synthesize, the diagnosis would be an acute encephalopathy with neuroregression following a febrile illness. So what could be the common causes of this presentation? Now, in our setups, and CNS infections come in varied presentations. In such a scenario, in a young infant who recently had a history of fever, we could still think of CNS infections with some complication or a course which has been punctuated by some use of oral antibiotics. However, when there's a prominent afebrile period following a brief febrile illness, we commonly think of 2 types of illnesses. It could be a para-infectious process, which is triggered by an underlying inflammatory response. So this could be a presentation of demyelinating disorders, or it could be a presentation of inflammatory encephalopathies. The other common other common possibility that you would think of in this scenario would be neurometabolic disorders. And typically, since you know from the previous what we have discussed, there's a trigger present in the form of a febrile illness, and the child has presented with acute intoxication. So we would broadly think of 2 types of disorders, which is either the intoxication group or the energy deficiency type, right? So when you think about the investigations, in our scenario, the first priority is to rule out the infections, especially when the patient is very young. So in this case, a CSF was done, which was non-meningitic, non-encephalitic. So the next common investigations that are available to us are the first-line metabolic tests, which are immediately done in the ER, and often neuroimaging. Sometimes it can be done within the first few days of admission, and sometimes patients come with a neuroimaging. So let us look at these investigations objectively. So the first line metabolic investigations are generally the Gaelic group of investigations, which means glucose, ammonia. You look at the pH in ABG, you look at lactate, electrolytes, ketones, and in our setup, you should also look at B12 levels. So this patient had anemia. She had also thrombocytopenia. Now this could be a sign of infection-related phenomena. This could also be seen in anemia. But if you're thinking of neurometabolic disorders, remember that anemia and thrombocytopenias or cytopenias are an important part of presentation of organic acidemias like methylmalonic acidemia or propionic acidemia. They are also sometimes seen in storage disorders. They can also be seen in acquired nutrition deficiencies. Now, the other investigations showed that there was a persistent, so there was a metabolic acidosis, there was high anion gap, and the bicarbonate was low. So there was a high anion gap metabolic acidosis with normal lactate values. In addition, the urine ketones were positive, and ammonia was initially high, which gradually settled. So if we are thinking of neurometabolic disorder, how do we place these findings? So if you look at the flow charts, typical flow charts of high anion gap metabolic acidosis, which this patient had, this leads us to ketosis. Our patient had a high iron gap metabolic acidosis and ketosis, and there was no abnormal skin involvement. So the common disorders that we would think of are again MMA, propionic acidemia, or isovaleric acidemia. Now, if you look at this, the flow chart for hyperammonemia, there's a mild hyperammonemia with metabolic acidosis, with ketosis and lactic acidosis. So this again also leads you to the same group of disorders. So our differentials among the first two categories of IMs are clinically till now organic acidemia or mitochondrial disorders, right? So we now come to the next set of investigations. In this patient, you would definitely go for neuroimaging and you would want to go for advanced testing. So let's look what does the neuroimaging add in such case scenarios or when you're dealing with neurometabolic disorders. So neuroimaging sometimes itself raises the possibility of a metabolic disorder in a child with a neurological presentation. So typically, what are the findings that make you think of an underlying neurometabolic disorder? So when you see symmetrical brain lesions on the MRI, or when you see lesions which are not explained by common mimics such as HIE or torch infections or demyelination, when you have an isolated or preferential involvement of specific brain structures like brainstem and cerebellum, which are usually not affected in other type of acquired insults, or you see persistent bilateral symmetrical involvement of structures such as basal ganglia or thalamus. When you have acute or chronic brain lesions, when you have non-vascular strokes, and when you see a progressive atrophy in the brain. So these are some of the imaging clues which make you think that the underlying insult could be a neurometabolic. Besides that, neuroimaging also helps us in the differential diagnosis and exclusion of mimickers. Occasionally, it can lead us to a specific diagnosis. It often in established disorders, it helps us in prognostication, follow-up, sometimes facilitation of targeting testing and therapy, and initiation of genetic counseling. In advanced research settings, it is also being used as a biomarker for some of the disorders. However, as clinicians and commonly dealing with children with sick children with neurometabolic disorders, I think the most important implications for neuroimaging are they either make us think about a neurometabolic disorder and they help us in excluding the differential disorders. So we have just heard about the basic MRI imaging techniques, and I will just be talking about the ones which are particularly relevant to neurometabolic disorders. So this is the typical T1, this is T2 and flare, this is T1 because remember that T1, Dr. Naveen has also explained it very beautifully. I will just put in a word that T1 exactly looks like a histopathology section. So in T1, the white matter will appear white, the gray matter will appear gray, and the CSF will appear black. The reverse of it would be T2. So you can easily identify T2 with the white CSF signal, and the flare would have features similar to T2, but the CSF would be black. Now, important sequence is diffusion weighted sequence, which helps us to differentiate between cytotoxic edema versus vasogenic edema. And contrast imaging is also sometimes relevant for some of the disorders, and MRS also helps in giving us some diagnostic clues. So when you look at the neuroimaging, you should develop an approach because you're trying to recognize a pattern which fits your diagnosis or not. So when you're looking at the MRI, our first approach should be we try to localize whether we are looking at involvement of the gray matter or the white matter. So these are the T2 weighted sequences, and the gray matter, as you know, is not only the cortex, which is gray here, but also the deep gray nuclei. So the gray matter and the white matter is, since this is T2, so this hypo-intense part is the white matter. So the first thing is we look at whether the gray matter is involved, and in the gray matter, whether it is the cortical gray matter or it is the deep gray nuclei. So the deep gray nuclei means bilateral caudate. This is putamen. This is bilateral globus pallidum, and these are the thalami. So these are the broad areas that we are interested in. If you're looking at the cortical gray matter involvement, there are common two patterns of cortical involvement which have been recognized in neurometabolic disorders. So one is the presence of swelling and cytotoxic edema in the acute state, and second is the presence of atrophy. So coming to swelling and cytotoxic edema, this is commonly seen on diffusion weighted images. So what you will commonly see this as diffusion restriction in some parts of the brain. So some of the inborn errors of metabolism, they can show diffusion restriction in their acute state or decompensated state. DWI images can also sometimes help us in assessment of the disease activity. So what are the common patterns that we see? In acute intoxication disorders like neonatal maple syrup urine disease or neonatal MMA or non-ketotic hyperglycemia, there is involvement of so there's diffusion restriction, which shows the involvement of the myelinated white matter. So since we have just learned that in the neonate, the white matter is not completely myelinated, and there are only few structures, mainly the structures in the posterior part of the brain are myelinated. So you will see diffusion restriction in these areas. In the urea cycle disorders, you see a typical ribbon-like restricted diffusion. In mitochondrial disorders, the restricted diffusion can occur at variable areas in the brain, sometimes in the cortex, in the deep nuclei as well. And typically in MELAS or Golgi-related disorders, you see metabolic stroke-like presentations with lactate peaks on MRS. So these are some of the pictorial examples. So this is a child with Golgi-related mitochondrial cytopathy. You see this ribbon-like diffusion restriction in the perirolandic areas bilaterally. You can also see typical diffusion restriction in the thalamus and the cortex, posterior cortex here. In the MSUD, this is the T2 weighted image. So what you see is there is a lot of edema in the bilateral symmetrically involvement of the white matter, as well as you see these in the pons, you see these 4 dots, and you see involvement of the cerebellar white matter. And the diffusion images show diffusion restriction in the exact same areas. So when you are looking at disorders like non-ketotic hyperglycemia, again, you see diffusion restriction in the posterior limb of the internal capsule, anterior limb of the internal capsule, and the white matter tracts. So aminoacidopathy sometimes can typically involve, so some glycine pathway defects or purine pathway defects or phenylketonuria that typically have diffusion restriction in these myelinated areas. So this peculiar diffusion restriction can sometimes be a clue to these disorders. Now, when you look at the DWI images, as already discussed, you have to keep some differentials in mind. So ischemic strokes also show an intense diffusion restriction, but then the important part in that metabolic disorders do not follow a vascular pattern. So this is how we differentiate them from ischemic strokes. Sometimes encephalitis and infections also can have acute diffusion restriction. It can also be seen in a patchy manner in the post-ictal stage. So be careful about those patterns. And beside the mitochondrial disorders, there are certain other disorders which can also have patchy diffusion restriction. So these are the DDs that we should keep in mind. Now, the second important pattern is the atrophy. Now, atrophy can be a non-specific feature. It is often seen as the neurometabolic disorders advance. Now, a typical diffuse atrophy of the brain, which involves the cerebrum and the cerebellum, and more prominently the cerebellum, along with these periventricular white matter changes, would be NCL in it. And of course, you have to keep in mind their background clinical scenario. Now, in disorders like Alpers disease, you find a posterior dominant atrophy, which is generalized, but there is a posterior dominance, but there can be evidence of hepatic dysfunction. There'll be a lot of seizures, and there can be involvement of the deep gray matter as well. Now, in storage disorders, typically you see the hypointense thalami. So this is the image from typical storage disorder. This is the T1 weighted image, and this is the T2 weighted image. What you see here is that the thalami, because of the storage, because of the presence of storage material, the thalami appear brighter on T1 images and they appear dark on T2 images. So this dark thalami or the hypointense thalami sign in a correct clinical scenario is often a clue towards storage disorder, along with abnormal myelin and cortical atrophy. Now, the next part that we see in the gray matter is the deep gray nuclei. So the main deep gray nuclei that we concentrate on are the bilateral caudate nuclei, putamen, GP, and thalami. Now, you can look up this pattern of involvement in any of the textbooks. So I'm not going to go through this. You can. It is wise to remember some types of patterns of at least some of the common or prototype diseases so that you can make a diagnosis. I'll just show here some of the representative images. So let us look at the one more point. When we say striatum, we generally mean the involvement of the caudate and the putamen together. So let us look at the involvement of these deep gray nuclei. So this is an example. These are the DWI weighted images. What you see here is that there is bilateral putamen involvement in the form of diffusion. So since these are DWI images, we will say that there is bilateral diffusion restriction in the putamen, and this is a typical case with organic acidemia. In this second panel, you see involvement of bilateral caudate and putamen with signal change, some cystic change and atrophy, and you also see patchy involvement of bilateral thalami. So the clue towards a neurometabolic disorder, even if without the clinical scenario, you look at this imaging, you see bilateral symmetrical involvement of the white matter, bilateral thalami, bilateral striatal involvement, along with symmetrical involvement of the midbrain and substantia nigra. So these are the typical changes seen in a mitochondrial disorder. You can also call this as a leak disease. Now, you see a similar changes with bilateral striatal involvement, which means bilateral putamen, bilateral caudate, bilateral thalami, and a very characteristic subcortical involvement of the white matter. So this is the typical presentation of biotin-thiamine responsive basal ganglia disease, or BTBGD. When you see this type of T2 weighted image where you have widened opercula, you have bilateral striatal injury in the form of caudate, abnormal signal from bilateral caudate, bilateral putamen, but sparing of the thalami with abnormal white matter. This is the typical presentation of glutaric aciduria type 1. And when you see a diffuse white matter abnormality with bilateral symmetrical striatal swelling and hyperintensity, this was a typical presentation of GM1 gangliosidosis. So if you just look at these neuroimaging, you will see that sometimes the presentation, radiological presentation, can be similar in several of these disorders. So that is why you need to have the clinical details as well as the first set of biochemical investigations. Now looking at differential patterns of thalamic involvement. So this image shows bilateral thalamic involvement and bilateral putamen involvement. This was a presentation of a mitochondrial disorder. Now here you see bilateral prominent white matter hyperintensities along with bilateral thalami involvement and bilateral GP involvement with typical sparing of the striatum. So this black appearing putamen and caudate is spared, whereas the bright areas are normal, and this is the typical presentation of a Canavan's disease. Now, in this case, you see diffuse bilateral cerebral atrophy along with dark thalami. So these thalami in the center are appearing heterogeneously dark, and this is a typical presentation of neuronal ceroid lipofuscinosis, which is a neurodegenerative disease. Now, this is a mimicker. What you see here is bilateral thalamic involvement with some signal change in the striatum. You also see a signal change in the corpus callosum, but what you see here is a superior, it's a straight sinus thrombosis. So a sagittal view shows the thrombus in the sinus, and that is why there's involvement of bilateral thalami. So remember, when you have acute bilateral thalamic swelling and involvement, also look for cortical venous thrombosis. Now, another important part is the globus pallidi. Now, globus pallidi can sometimes be isolated involved. So this is a T2 weighted image. You see bilateral GP hyperintensity. So the most common causes are kernicterus and organic acidemias. There can be variable involvement of the white matter with cerebellar involvement or other parts of the brain, and accordingly your differentials would change. Now, an important thing to see is to look for GP hyperintensities on T1 sequences. So as we have learned, generally on T1 sequences, these should not appear as bright. When you see T1 brightness, this is commonly related to mineral deposition, and a very important cause for neurological patients is manganese deposition. This can also be seen in acute kernicterus in the newborn babies. Now, coming to contrast enhancement, this generally has relevance more for demyelination. So when you're looking at leukodystrophies, contrast enhancement is sometimes very informative. So this characteristic pattern of contrast enhancement at the edges of demyelination is characteristically seen in X-linked adrenoleukodystrophy. This typical pattern of periventricular enhancement is also very characteristic of Alexander disease, and it can also have a brainstem presentation. So when you see a nodular brainstem enhancement, this is also a presentation of juvenile Alexander disease. Non-specific enhancement can sometimes be seen in Krabbe disease and mitochondrial disorders, and cranial and spinal nerve enhancements are very characteristic of metachromatic leukodystrophy and Krabbe disease. So you see enhancement of the cranial nerves. Now, coming to the role of MRS, this has already been alluded to. I will just discuss why it is important in neurometabolic disorders. So sometimes MRS may be the only abnormality identified. So it is very crucial for disorders like creatine deficiency, where your MRI can be normal. But if you're suspecting this disorder, you have to look for absent or reduced creatine peak. So creatine peak is normally present when there are creatine deficiency disorders. The only abnormality can be the absence of this peak. And that is why it is very important. Also in mitochondrial disorders, sometimes you can only have lactic acidemia and lactate peak in the brain, and the full-blown manifestations may not be there. But more importantly, MRS has a role in confirming the diagnosis. So when you are suspecting these specific disorders, they have their specific metabolite peak, and these are the specific positions. Since it is very difficult to remember, you can probably remember few of the characteristic ones. Now there is additional role of MRS. As I said, it can predict disease progression. So if the ratio of Na and choline is less than 5 in an otherwise normal appearing parenchyma, it shows progression of X-linked ALD. It can also be used to monitor therapy, like if there is reappearance of creatine peak in deficiency syndromes or Sjogren-Larsen syndrome, it probably means that the supplementation is going right. Also remember that lactate elevation can sometimes be seen in ischemic lesions or in critically ill children, or sometimes because of technical factors, and small lactate peaks can also be seen in normal neonatal brains. So keep in mind that the lactate peak has to be interpreted in the correct clinical context. Now coming to the big group of mitochondrial disorders. So just remember that the mitochondrial disease we typically know presents as a league-like pattern. And what is a league syndrome? Which basically means in the brain, it is typically the involvement of bilateral basal ganglia with bilateral basal ganglia, thalami, and the brainstem. Sometimes they can be isolated involvement of the brainstem and the spinal cord. The second more common pattern that we have often heard about is the MELAS spectrum. So MELAS are primarily because of the inherited, because of the mitochondrial DNA defects, and they present as stroke-like lesions on the brain. So there is cortical involvement, cortical swelling, and diffusion restriction. Now, a very important pattern to recognize is the predominant white matter involvement, wherein the mitochondria, these are primarily the respiratory chain defects, and they are encoded by nuclear genes. So they have an autosomal recessive inheritance. The characteristic pattern is of cavitating pattern. So you will prominently see the periventricular white matter cysts, but these cysts are typically, these changes are bilaterally symmetrical, and you will have cystic changes in the periventricular white matter. Sometimes there can be expansile lesions which are non-cavitating, and there can be only tract involvement and few other presentations. Now, there are other miscellaneous presentations also described with mitochondrial disorders, like there can be presence of malformations, mineralization, isolated cerebellar atrophy, or optic atrophy. So these are, if you have to summarize, these are the 4 more common patterns of mitochondrial disorders. Remember, again, league disease or league syndrome, the typical pattern of involvement involves the brainstem and the basal ganglia and thalami. So these are the most common patterns of involvement. So if you have a correct clinical scenario and you see involvement of bilateral basal ganglia, midbrain, and the brainstem, then probably you are dealing with the case of League's disease. This is one case which also shows the typical presentations where we prove the disease by histopathological evidence also. But what you see here, these are the T2 weighted and T1 weighted images, and these are the diffusion restrictions. So in the acute state where there is swelling and injury to these parts, there is an intense diffusion restriction in these areas. And again, then there is the inverted lactate peak on the MRS. So these are the other clues towards League disease. The other common pattern is the stroke-like episodes in a child with progressive myoclonic epilepsy and presence of lactic acidosis. This gives us a clue towards MELAS. So the typical pattern is that your patient can have a stroke-like focal deficit. When you look at the imaging, the lesion has diffusion restriction, but it does not follow a vascular territory like a stroke. So that is where you think, and if you go ahead with MR angiography, you do not find evidence of vasculopathy. So presence of stroke-like lesions which do not follow vascular territory, and your patient has a focal deficit, and you are thinking of mitochondrial disorders, then you're probably dealing with MELAS. So this is the third pattern, the cystic pattern, which can have cysts in so many areas of the brain, but it is predominantly in the periventricular white matter. Just a word about inborn IEMs, which can present as stroke or stroke-like episodes. So homocystinuria can present with a true stroke, but disorders like organic acidemias and OTC deficiency can present with stroke-like lesions. So can MELAS and congenital disorders of glycosylation. So I'll just show the images here about the pattern, the stroke-like presentation. So when you are dealing with disorders like MELAS and CDG, you have these non-vascular territory strokes, which primarily present with diffusion restriction. So these are diffusion restriction, this is diffusion restriction in these areas. When you're dealing with conditions like League syndrome or organic acidemia, glutaric aciduria, you have bilateral striatal involvement, which can also present as a metabolic stroke. When you're dealing with disorders like Fabry disease, you will have recurrent lesions. You will have acute and chronic lesions, but the lesions will appear in close proximity of each other. Now, just a word about why the metabolic stroke occurs. So this is a normal neuron, the astrocyte, and the capillary in the brain. What happens when there is an acute decompensation? There is a failure of energy in this neuron. So you can see that this neuron is swelling up along with the swelling up of its projection. So what this does is that it starts compressing the capillary. Now, when the capillary is being compressed, because of the ischemia, the blood is getting shunted from the arterial branches to the venous circulation. And also because of this, there is dilatation of the venous circulation, impairment of the arterial supply. So this leads to ischemia and venous stasis. Sometimes these venous channels can rupture and lead to hemorrhage. Otherwise, this occlusion starts leading to weakening of the vessels by the elevation of vascular endothelial growth factors. So this can lead to ischemia and rupture and swelling, which leads to the presentation of a metabolic stroke. Now, coming to the other part of the brain, which is the white matter. So when you're looking at the imaging and you're looking at white matter involvement, this has already partly been discussed, so I'll just be brief about it. The first and foremost thing is to remember the myelination. So if you look at the myelination pattern in the brain, just remember this visual impression. So if you see the brain from birth, 5 months to 12 months, you see that these are the T1 weighted images. The white areas are the normal myelinating areas of the brain. And the rest of the brain you can see has not myelinated because you do not see in the T1 image, white matter should appear white and it is still not appearing white. So in a newborn, only the posterior limb of the internal capsule has myelinated in this section. And as the age advances, this myelination is progressing. So by 5 years, by 1 to 2 years, it's almost an adult brain. So you see between 1 year and 5 years, there's not much difference in myelination, but you can now see that the white matter is white and the rest of the gray matter is gray. These changes lag behind in T2. So the myelination in T2 can be appreciated after a gap of 2 to 3 months in the same areas. But again, you see that at newborn, this white matter is abnormally hyperintense in T2 image and gradually it becomes hypointense. So what is important to remember is that as myelination progresses, in the T1, white matter starts becoming more white, and in T2 images, it starts becoming more black. Remember, the myelination progresses from posterior to anterior areas of the brain, from caudal to cranial areas, and from center to the periphery. And that is why in children less than 1 year, for myelination assessment, we try and look at the T1 images because T2 images are always appearing bright. But after 1 year of age, for myelination, we try and look at the T2 sequences. And for serial imaging, for assessment of hypomyelination, you often need serial imaging. So when you see an abnormality of white matter, what is important to determine is whether it is hypomyelination or it is demyelination or dysmyelination. So hypomyelination means the myelination is not progressing or is arrested. Dysmyelination means the myelination was formed, myelination was there at some point, and because of the pathology, it is now getting destructed. So what is the primary difference? If this is hypomyelination, in T2, your myelin area, the myelinated areas will still appear bright. Whereas if it is demyelination, in T2, it will be very abnormally bright, and on T1, it will become hypointense. So these are the classifications of hypomyelination disorders. It will probably not be possible to cover all the patterns. So just remember, when you're looking at white matter abnormalities, the primary thing is to first differentiate whether it is hypomyelination or demyelination. And then if it is hypomyelination, you're probably dealing with hypomyelinating leukodystrophies. And based on the pattern of involvement, again, a presumptive diagnosis can be made about the underlying etiology. So again, this is the normal myelination pattern. So this is the newborn and advancing myelination. Now, when you see at this image, this is a T2 weighted image of a child who's beyond the neonatal period. Now, this MRI by visual impression almost looks like this MRI. So you know that let's say if this is a 2-year-old child, this myelination is not appropriate for 2 years because by now this white matter should have become hypointense on a T2 weighted image. So if you visually compare this image with this image, this looks almost like a neonatal brain in a 3-year-old child. So this should be your first clue towards looking probably at the MRI, which is an underlying hypomyelination. This is another case of a child with Paul-G related mutation. And this is the, again, T1 and T2 weighted sequences. So again, in T2, the MRI, the white matter is bright, and on T1, it doesn't look like myelinated. When you're looking at leukodystrophies, which are dysmyelinating or demyelinating, again, there are different ways of classifying and different patterns of classification. So it is not possible to remember all of them, but you can remember some of the common patterns of common leukodystrophy. So for example, if you're looking at X-linked ALD, you see this
I'm
typical.
extremely sorry, Dr. Arushi, you have 3 minutes left. Okay.
Yes, sir, sure,
sorry.
sure.
Okay.
No, not a problem. So as I was saying, if you're looking at demyelinating leukodystrophies, try and remember some pattern, whether the involvement of the white matter is periventricular, whether it is posterior dominant, whether it is cavitating, or it is anterior dominant, or it is involving other parts of the brain as well. So I'll just sum up with the index case. So in the index case, the original 8-month-old child, this is a normal MRI of an 8-month-old child, and this is the MRI of the index case. You can clearly see that this is abnormal. What is the abnormality here is bilateral abnormal signal in the white matter as well as bilateral striatal involvement. And there is an intense diffusion, there's a diffusion restriction as well. So this gives you a clue that probably you are dealing with acute intoxication type of disorder. When we looked at the other metabolic testing, we found the abnormalities of C3 metabolite in the urine and the blood. And finally, we made a diagnosis of propionic acidemia. So this was a genetically proven case of propionic acidemia. So I will skip about, I had planned to discuss the X-rays of complex molecules, because in the storage disorders, MRI may not be that informative, but the X-rays are really informative. But I suppose this would have been covered in the sessions of X-rays. So I would like to conclude that inborn errors of metabolism and neurometabolic disorders in particular may sound individually rare, but collectively they're very important. There may be a significant overlap if, as far as neuroimaging features of the various disorders are concerned. And abnormalities found on the MRI do not always correlate with the clinical disability. And that is why you need a comprehensive assessment of the clinical, biochemical, and the radiological features, and always have a systematic approach of synthesizing your information so that you can reach proper diagnosis. You may and may not be able to confirm it, but at least suspecting and reaching towards a diagnosis can make sometimes a huge difference to the patient's care in your setup. So thank you.
Thank you, Dr. Arushi, for your mesmerizing talk, very lucid and covering the clinical aspect as well. I think it will be helpful for general pediatrician and the residents to, as I have elaborately described, also the clinical aspect of it. There are 2 questions in the chat box. So what is the ideal age and time to go for MRI if you suspect neurometabolic disorder?
So there is no ideal age or time. It depends on what your patient is and what is your objective. So when you have a sick patient, there is no ideal time. Even for a sick neonate, you will have to do the MRI if you want to reach a diagnosis. But let's say if you're talking about a patient who has a non-progressive illness, something like a global developmental delay, and you do not have an urgency of diagnosis, sometimes to look at the MRI changes, you may have to wait till 1 year of age, or you may have to repeat one MRI. But if you're trying to make a comprehensive diagnosis, I think there are clues at every age. So you just have to know what are that for your particular patient.
Thank you. And another, I think one of the participants want to again go through the approach of high anion gap metabolic acidosis. I think you have already described it, but you can just post the screenshot of that in the chat group so that they can just see the approach slide. Okay.
Okay. This is a standard flow chart which is available everywhere in all the textbooks. Even if you search Google, you will find it. The key is not the flow chart. The key is how you use it. So you post different scenarios and try and use the chart, because otherwise you will never remember the chart. So try, and I would suggest rather, if you are a MD resident, try and draw the chart yourself and then see if you, with this understanding, you can actually make an approach yourself. It is pretty much same. I think it's given in Nelson also.
Thank you so much, Dr. Arushi. I think we should now proceed to the next session. Over to you, Dr. Pradeep, to start with the next session.
Thank you, ma'am, for your excellent talk. Our next speaker is Dr. Govind Pramanik. He had done his DM residency from PGI Chandigarh only. He is now a consultant intervention and neuroradiologist in R.N. Tagore Hospital, Kolkata. Dr. Govind Pramanik, sir.
Hi, very good evening to all. Can you hear me?
Yes, yes.
Yes, sir. Yes, sir.
You share your slide.
Yeah. Is it visible?
Yes, yes.
Yes,
Please
sir.
go ahead.
Okay. So I will talk about imaging overview of common neurocutaneous syndrome like neurofibromatosis 1, 2, and tuberous sclerosis, VHL, and that Sturge-Weber syndrome. So you know that neurocutaneous syndrome is a heterogeneous group of disorders which are usually having abnormalities of both skin, eye, and some CNS involvement. And most of these disorders are familial. So I will mainly focus on the imaging part because I think clinicians know better than me about the clinical aspect of this neurocutaneous syndrome, because most of the time what I see that it is a clinical diagnosis rather than imaging diagnosis. What we do, we just confirm the clinical diagnosis with our imaging. So most common neurocutaneous syndrome we see is the neurofibromatosis 1. So you know that clinical scenarios, you can get multiple cutaneous lesions in the form of cafe au lait spot, freckling of the armpits, and eye abnormalities you can see in the slit lamp, in the lesion nodule, and bone lesions. And there is most of the time there is a first degree relative with the NF1. So this is the huge list of imaging finding we encounter in neurofibroma. I will just go through my imaging to show all these findings. So clinically, you can see all this. Whenever you see patient, you should always look for the neurocutaneous marker, which most of the time give us the clue to the final diagnosis. Like in this case, in the you can see multiple cafe au lait spots, then multiple dermal neurofibroma. All these are quite pathognomonic of NF1. So in imaging, you can get a number of findings like plexiform neurofibroma. Plexiform neurofibroma is pathognomonic actually for NF1. You can see here in this is a T2 weighted axial scan at the level of the maxillary sinus, where we can see transfacial lesion extending from the right cavernous sinus, then it is going into the pterygopalatine fossa, then we can see it is extending into the masticator space. So one thing is important, you can see that it is a transfacial lesion, and imaging quite characteristic finding you can see. If you the cross section of this tumor, you will see it is a target-like appearance. This is in the central hypointensity surrounded by hyperintensity. This is quite characteristic of NF1 lesions. So sometimes you may get this kind of extensive plexiform neurofibroma arising from the cervical nerve roots. Here we can see the plexiform neurofibroma, which is arising from the lumbar plexus. You can see all the lumbar nerves are fusiformly dilated, hypertrophied, and these are all plexiform neurofibroma. In neurofibroma, you may get cutaneous lesions. That is a dermal neurofibroma, which is hypointense in the lesion. We can see in the T1, we can see hypointense lesion. And sometimes you may get bone infiltrative lesions. This is the lesion which is involving the calvarium and which is showing enhancement of the post-contrast sequence. Neurofibroma is most commonly associated with pilocytic astrocytoma, but in the orbit you can see that it may be associated with optic nerve glioma. Optic nerve glioma, how does it look like? It appears the optic nerve is fusiformly dilated. You can see it is a bulky optic nerve which is within the orbit, and in addition you can see this there is a patulous left sided Meckel's-Cave which is also seen in the NF1, and we can see there is plexiform neurofibroma in the left masticated space. This is quite characteristic tumor in the NF1, that is the optic nerve glioma. This is another finding we see in the NF1, that is the enlarged orbit with absent sphenoid wing and leading to because large superior orbital fissure. And other finding is that you will see, you may see this kind of appearance, that is an extensive dural ectasia. You can see this is the lumbosacral spine where we can see extensive dural ectasia. This is all dural ectasia causing there is a scalloping of the posterior aspect of the vertebral body. So this is called dural ectasia, and we can see the meningocele formation. Here we can see that the Meckel's-Cave is also dilated, over distended, as well as we can see the internal auditory canal dural space is also distended. So as I said that the most common tumor associated with NF1 we can see is the pilocytic astrocytoma, which may involve the brainstem and which may involve the optic tract. Like here we can see the lesion is T2 hyperintense lesion involving the pons and midbrain, and in the post-contrast sequence we can see the lesion is enhancing, and we can see the enhancement of the optic radiation and the optic chiasma also. So this we see in the NF1 case. Even we can see the small pilocytic astrocytoma here. This is a T1 sequence where we can see a small cystic lesion in the right parietal lobe, which after giving contrast, we can see there is a enhancing nodule. So this is classical appearance of the pilocytic astrocytoma. These are actually benign grade 1 tumor, but many times it may be malignant tumor. Here we can see a large lobulated, intensely enhancing lesion with extensive surrounding vasogenic edema in the temporo-occipital lobe. This is actually a high-grade tumor, high-grade glioblastoma. So yeah, NF1 may be associated benign low-grade glioma and high-grade glioma also. So many times you can see that NF1 spots in the brain. So you may say these are all incidental. Many times you may get incidentally, you can pick up these findings. You can see there is a, here you can see there is a small T2 hyperintense round lesion in the left globus pallidus, and right globus pallidus also you can see. These are actually called NF1 spot or focal abnormal signal abnormal alteration of the signal intensity. So or unidentified bright objects. These are probably because of the myelin vacuolization. So now I'm showing one case. This is a child actually who came to us with acute stroke. We can see some diffusion restricting lesions in the left centrum semioval. And in addition to that, we can see some T2 flared hyperintense signal along the optic radiation and in the thalamus and the posterior aspect of the putamen. So here we can see better. So these are actually the NF1 spots I was talking about, and these are actually the infarct because this was showing diffusion restriction. So we did an angiogram And we found that there is a severe stenosis at the left supraclinoid ICA. This is the normal ICA on the right side. This is the abnormal ICA. This we can see a severe stenosis at the left supraclinoid ICA, and downstream that we can see this collapsed cervical part and the petrous and cavernous part of the ICA. So this is the cause of the watershed territory infarct on the left side. So when we see all these findings together, we thought this is probably a case of NF1 related moya disease, because NF1 may 10% NF1 cases we can get moya pattern of involvement. Typical, it may be unilateral, it may be bilateral. So it was a case of NF1 related moya disease. Coming to second common, that is the neurofibromatosis type 2. As you know that this is a characteristically associated with bilateral vestibular schwannomas, and it is the acronym is MISME, that is multiple intracranial schwannoma, meningioma, and ependymoma. It can be associated with multiple intracranial schwannoma, meningioma, ependymoma, MISME. So I will show you. So whenever you see this kind of two vestibular schwannoma, bilateral, both sides you can see, so it's a quite pathognomonic of NF2. Whenever you see these two bilateral schwannoma, you should look for other tumors like other meningiomas, ependymomas, all these tumors you should look for. Here we can see that this is a bilateral vestibular schwannoma and multiple calcified dural-based lesion. These are multiple meningiomas, intracranial meningiomas. So this can the lesion can also be seen in the spinal cord. We can see multiple this meningioma in the spinal cord, and some of them are the in the central intramedullary lesion, that is the ependymoma. And in the conus region, you can see multiple nodular lesions along the conus medullaris and the cauda equina, so which are showing enhancement. So these are called actually tumorlets, which may be seen in the NF2. So multiple intracranial schwannoma, meningioma, and ependymoma can be seen in the NF2. This is another case where we can see multiple meningioma in the spinal cord and in the conus region. So tuberous sclerosis, in this neurocutaneous syndrome, you will also get clinically, you can diagnose actually, because there is a multiple clinical findings. You can see adenoma sebaceum, and then you can see there is a hypomelanotic macules, facial angiofibroma, Sjagren patch, subungual. So multiple clinical clues are there for tuberous sclerosis. So in the imaging, in the clinically, you can see there is a adenoma sebaceum. You can see that these are the actually dermal angiomas, and you can see subungual fibroma. And here is a case, we can see there is a hypomelanotic macule, we can see, and the Sjagren patch. So these are quite characteristic of the adenoma sebaceum, this area, this location. So these are the clinical pictures, and in the MRI and the CT scan also you can find there is a calcified nodule, subependymal nodule. This is quite classical appearance of the tuberous sclerosis. This is actually a spotter, no other diagnosis if you see this kind of calcification along the ependymal surface. So, and one characteristic thing is that it we can see in the foramen of Monro here. So here we can see the lesion is quite big and it is showing enhancement. So this is another case where we can see there is a flared hyperintense lesion in the foramen of Monro, anterior third ventricle. This is and we can see multiple other subependymal nodules. In addition, and the lesions are showing enhancement on the post-contrast sequence. These are the classical location of the actually subependymal giant cell astrocytoma near the foramen of Monro. And in the brain parenchyma, you will see there is a expanded flared hyperintense or T2 hyperintense cortex. Multiple areas you may see, the cortical and juxtacortical areas. So this is T2, where we can see multiple T2 hyperintense cortical juxtacortical lesions, which are also hyperintense on the flare sequence. And this is the classic location, as I said, that the subependymal giant cell astrocytoma. And when it is calcified, it appears hypointense on T2 weighted sequence, this subependymal nodule. And you can see multiple cortical, juxtacortical, expanded cortical tubers. So here you can see there is a large subependymal giant cell astrocytoma, or we call it SEGA. And in the brain parenchyma, you can see multiple cysts in the tuber sclerosis. We can see these are the CSF intensity cyst in the white matter. So these are actually we can be seen in the tuberous sclerosis. This is a large giant cell subependymal giant cell astrocytoma. This is a classical location. So here it is a case where we found multiple cortical juxtacortical tubers, which appears as an expanded cortex and flare hyperintense, and it may calcify later on in the especially in the adult age, and we can see multiple subependymal nodule here and here in the typical location. So whenever you see this kind of imaging finding, there is no other differential. We should think of tuberous sclerosis. If you just correlate, you need to correlate with the clinical findings, like all the cutaneous manifestations and clinical manifestations. So this is the MRI phase sequence where it can show which lesions are calcified. So here you can see the one of the lesion in the foramen of near foramen of Monro is calcified, which appears white in this sequence. So in the MRI, we can see calcification as white in this sequence. So in tuberous sclerosis, you may get multiple angiomyolipoma. Here, like in the same patient, we can see multiple renal lesions. Here, multiple renal lesions. These are angiomyolipoma. Coming to von Hippel-Lindau syndrome, this is another neurocutaneous disease. Here, main involvement is the eye, that is the retinal hemangioblastoma, and other CNS tumor. You can get endolymphatic sac tumors, and visceral lesions. You may get renal lesions, adrenal pheochromocytoma, pancreatic cyst, epidermal cysts. So when you see multiple hemangioblastoma, usually hemangioblastoma happens in the adult population, but if it is syndromic, like if it is associated with VHL, it can be seen in the younger age group. So most of the time, this hemangioblastoma in VHL is cystic, but 1/3 case, it can be solid also. So in the retina, you will get hemorrhagic retinal detachment, and sometimes you may get retinal hemangioblastoma also. And in the you may get endolymphatic sac tumor in the temporal bone. So here we can see there is a large cystic tumor lesion in the left cerebellar hemisphere, and another lesion we can see here is a smaller cystic lesion with an eccentric mural nodule, and this nodule usually abuts the pial surface. So, and it is the wall of this lesion doesn't show any enhancement, only the eccentric nodule shows enhancement. So whenever you see multiple this kind of lesion, so you should think of VHL. So actually, this is the pituitary stalk, which is also showing enhancement, thickened. So this is the most common site of supracellular, actually, this supratentorial hemangioblastoma. And you can get also hemangioblastoma along the cord surface. And you can see this hemangioblastoma are actually very vascular lesion. So you may get the feeding arteries, which is leading to the lesion. Here we can see this is the feeding artery, which is leading to this lesion. So when it is a very large lesion, you may get large multiple AVM-like feeders to that lesion. Here in the this is the if you do the digital subtraction angiogram, you can see that the lesion is very hypervascular. We can see multiple vascular channels within the lesion, and it is showing significant blush in the, this is the left vertebral angiogram, where you can see this is the lesion, which is showing extensive tumor blush. So in such case, if surgeons wants to operate, many times they ask for preoperative embolization because of its hypervascularity. We can do the preoperative embolization and subsequently we can go for surgery. So these are multiple other hemangioblastomas along the cord surface, which are showing intense enhancement. These are solid appearing. And in the retina also, we can see there is a hemangioblastoma leading to, there is a retinal detachment. So in VHL, you may get endolymphatic sac tumor. Here, this is the location of the endolymphatic sac between the internal auditory canal and the sigmoid sinus. So you can see a lytic destructive lesions in the petrous. This is the petrous bone, where you can see the lytic destructive lesion. So if you see this kind of lesion, and along with you see other findings, you should think of the von Hippel-Lindau syndrome. So neurocutaneous melanosis. This is not a very common neurocutaneous syndrome, but I came across one a few days ago. So that is, it is actually because of deposition of the melanin along the leptomeninges, amygdala, and cerebellum. And in the cutaneous, you will get hairy nevus, and you can see this is the patient's skin, where you can see hairy nevus through extensive. And this patient actually came with a hydrocephalus, and clinician thought it is probably this is a case of tuberculosis. And then we did all the investigations. The CSF was not very conclusive for infection, but suddenly one of the residents found that this patient is having this kind of cutaneous manifestations. And then I saw this image, and we found that there is a in the T1 weighted sequence, we can see multiple T1 hyperintense lesions along the leptomeninges. Here one lesion, there one lesion we can see here, and along with that we can see a Dandy-Walker cyst. So here we can see the multiple T1 hyperintense lesions. This is the T1 sagittal sequence. We can see multiple T1 hyperintense lesion along the sulcal spaces, along the leptomeninges, and there is a Dandy-Walker malformation. So this may be in neurocutaneous melanosis, you may get Dandy-Walker malformation, and this melanin deposit. Melanin appears hyperintense on T1. So this was a case of neurocutaneous melanosis. So many times you may see multiple vascular neurocutaneous syndrome like Starch-Weber syndrome, then Fay's syndrome, and all these out of these most commonly we see that is the Starch-Weber syndrome, which is has a very classical clinical appearance. That is the cutaneous. You can see the large port-wine stain involving the one side of the face. And if you see this, most of the time you will see in the brain parenchyma, you may see there is a gyriform areas of calcification, and there is cortical atrophy. And this is a quite classical, only this is a spotter actually in the imaging. No other diagnosis, you should think of the Starch-Weber syndrome if you combine these findings and these clinical cutaneous findings. In MRI, actually, what will you can see there is a classic leptomeningeal enhancement. You can see the pile enhancement, which is because of the pile angioma. you can see there is extensive enhancement and there is a large choroid plexus, you will see. So this is seen in the Sturge-Weber syndrome. Here again, this is another case where we can see there is a large choroid plexus. This is the normal choroid plexus. And this is we can see there is a pile enhancement here along the occipital region. And in the here also we can see the choroidal, you can see the choroidal blush also in in the Sturge-Weber syndrome. So these are all actually the common neurocutaneous syndromes we see most of the time in our practice. But there are many other rare neurocutaneous syndrome like Faramani syndrome, Proteus syndrome. You can see Face syndrome, so Cowden. So those are very rare, very rare. But these are the common neurocutaneous syndromes we should know actually in our clinical practice. Thank you very much.
Thank you, Govind sir, for your very informative and lucid presentation. It will be quite helpful for all of us. For resident, I think the field of tuberous sclerosis and Sturge-Weber syndrome are most important, and I think these films are there in all the colleges for exam purpose. There is a question from Sopun sir. There is a type of Sturge-Weber syndrome and how to differentiate.
Actually, that is depending on the clinical findings actually. So whether it is type 1, type 2, type 3, I can't remember exact classification, but I think that there is a skin manifestations in the type 1 and the type 2, you can get both actually skin and plus CNS manifestations. And this, I'm not sure, but there is a classification like the involvement of the...
You are absolutely right. It totally depends upon the clinical manifestations. So some you will have a hemangioma, what you have shown in that particular picture on the left side of the face. So Port-Wine stain, and sometimes you will only get the leptomeningeal involvement, and sometimes in the third variety you can get only the pial angioma. So I am not getting this article. I have read in some book somewhere, but I am not getting it. So as you are giving so much of your details, the on people Lindau disease, I thought you must have that article. Please send me.
No, I don't have that right now. Sorry.
Because I am not getting it further, not even written in the Barkovich.
Another question, sir. So is it necessary to do MRI brain routinely for neurofibromatosis?
Yeah, routinely we don't do, but if there is any clinical manifestation, like in the case I showed, that patient came with a stroke, so pediatric stroke. So patient came, they asked for MRI, and I found there is a stroke, and I asked for angiogram, and I saw that NF1 spots. NF1 spots, classical, that is the myelin vacuolization I showed. That is T2 and flare hyperintensity. You can see in the bilateral basal ganglia, brainstem, you can see. And when I saw those findings, and there is a moya pattern in the angiogram, I asked the residents, have you seen is there any cafe au lait spot in the child? He was not sure. I asked him, go and check it. And then he called me, yes, sir, this child has got multiple cafe au lait spots. So it is actually the clinical, when there is some clinical manifestations only, like the stroke and all, then only we do, like there is a deforming face and all. In that case, you can do the imaging. Otherwise, we don't do.
No more question is there. Thank you, Govindu sir, for your excellent presentation.
Thank you.
We want to go for the next session. The next session, our speaker is Dr. Sonali Singh. He completed her DM in pediatric neurology from prestigious AIIMS Delhi. He is She is consultant pediatric neurologist in Institute of Neurosciences, Calcutta. And her topic will be neonatal MRI brain with patterns in HIE. Dr. Sonali.
Yes, thank you, Dr. Pradeep. I'll just share my screen. Dr. Pradeep, can you see my screen?
Yes, yes.
Okay. Thank you so much. So good evening to all the panelists, my dear seniors and dear attendees. A big shout out to WBIAP for coming up with such a brilliant teaching program. So my topic today is this neonatal MRI brain with pattern in HI, including the structural correlates of cerebral palsy. Now, because my topic is the last one, so it's kind of a little easy for me, because by this time we have a fair idea of how to read the MRI, its anatomy, and how to interpret it. So just to brush up, because in this talk, we are basically going to deal about neonatal MRIs and the insult pattern. So 3 things that I'd like to point out, which we usually use in the OPD for all practical purposes, is the things that we look at MRI are the development of sulci, myelination, and changes in free water diffusion. So the other 3, yes, theoretically, they do differentiate a neonatal MRI from that of an adult. But for all practical purposes and relevant to the topic of this discussion, we will basically be concerning with development of sulci and myelination. So this is just a brief about the neuroanatomy. Dr. Pradeep, is my cursor visible?
Yes, yes.
Okay. So the neural tube, the most cranial part, it develops into 3 bulgings, which is prosencephalon, mesencephalon, and rhombencephalon, which further divides. So prosencephalon divides into further 2, rhombencephalon divides into further 2. And then finally, it forms this basic structure. But one thing that I'd like to point out here is that in its early development, the brain is very smooth. So the kind of impression that we have about brain, a very large surface area with sulcus and gyri, it is not present in a very primitive brain. So this is just a schematic representation of development of brain. So as the gestation age progresses, the size of the brain increases, plus at the same time, the sulcus and gyri, this increases. So actually the surface area increase, and this is what it is, that a major part of the brain is actually hidden, because this pattern of sulcus and gyri actually are responsible for the development of higher functions and all later on. So why this is important? Because when we are going to read a neonatal MRI, so say somebody says that this is a MRI of a 3-day-old baby, further information that we are going to need is what is the gestational age of the neonate? Because now with increasing services and good neonatal care, we are actually seeing very young neonates, very young, like by gestational age, surviving. So gestational age is very important before we start interpreting a neonatal MRI. Now here what I have shown is the first 2 images. Okay, so one very important thing to know is for this particular discussion, that is the pattern of injury on the MRI, which we are going to correlate with the clinical history. Okay, so this is what the main purpose of today's topic is. We don't actually need to look at the difficult sequences of MRI. T1 and T2, it's sufficient to identify the pattern of injury, and that too T2 kind of mainly. So for all practical purposes, T1 is what we look at for anatomy. T2 is what we look at for the pathology, because the signal changes and all are very well appreciable on T2. And easy to identify, gray is gray, white is white, CSF is black on T1. And on T2, it's just the reverse. So the CSF is white, gray matter is white, or rather lighter shade. And this is the white matter, which we can see as the darker shade. So this is of the same child, and this child is 3 years old. So for all, this is a normal MRI, normal T1, normal T2, axial sections. Now say we start looking at this third MRI and somebody questions you, is this a normal MRI or this is abnormal? So yes, if I get to know that this is the MRI of a 3-year-old child, this is definitely abnormal. Why? Because this is the T2 sequence. Why do we say so? Because the CSF is white. But the white matter is of the lighter shade, which otherwise in a normal 3-year-old child should have been darker shade. And the gray matter is darker. So if the information is that this is of a 3-year-old child, this is definitely on a way we can say that this is hypomyelination. And we don't even require a repeat MRI to say that. But if somebody tells you that this is the MRI of a full-term child born at 40 weeks of gestation, day 4. So this is a normal MRI. So that is why the importance of knowing what the age of the child is. Now in this MRI itself, I like to point out 2 other things which we usually find in neonatal or rather early infants, which sometimes is interpreted as abnormal, which is actually a physiological finding. So this anteriorly, as you can see that we have a enlarged extraaxial CSF space, which is otherwise not found in this which is otherwise not found in this 3-year-old child's MRI. So this expanded extraaxial space, if it was present in a 3-year-old child with increased sulci spaces. So there is some evidence of atrophy of the parenchyma with increased space. This would have been abnormal. But for a neonate at day 4, this is normal, and this is just benign enlargement of the extraaxial space. As we can see, the parenchyma underlying it is completely normal. There is no evidence of atrophy. Now, the second thing that I'd like to point out is this periventricular region, which often appears white, which often appears of a lighter shade or hyper intense on T2. And it's sometimes reported as sequelae of hypoxic ischemic injury. So what happens is this is the area of terminal zone of myelination. What does that mean? That this is one of the areas which is myelinated at last. So that is why in a child less than 2 years of age and sometimes even less than 5 years of age, if we are finding hyperintensity only in the periventricular region without any evidence of volume loss, so the white matter thickness is normal, the ventricular margins are normal, there is no wavy kind of a pattern as we will see later for children with periventricular leukomalacia. So we should be very guarded in reporting or reading these patterns as abnormal. Now moving on, here we have 3 patients. Okay, so this upper row is T1 weighted sequences and the lower row is T2 weighted sequences. And each column is of the same patient. So the first 2 images, T1 and T2, it is of the same patient which we saw earlier. Now the question is, are these images normal or abnormal? So the first one we know is a 3-year-old. This is not basically a neonate, but I have kept these images just for a reference purpose. Let's look at these 2. So the second information that I'd want to know before interpreting these as normal or abnormal is what is the gestational age and what is the actual chronological age of the child. So the second image is that of a term child at day 4. So this is essentially a normal MRI. In this MRI, of course, on T2, the white is white, gray is gray, CSF is white. T1, it's just the reverse. And so one thing that we'll have to remember is that T1 myelination always precedes the T2 myelination by a couple of months. So here what we can see is this posterior limb of internal capsule is already myelinated, and maybe a part of it is probably a little hypointense on T2, which may be a beginning of hypomyelination. But otherwise, as far as T1 is concerned, this is a normal MRI. So for a term day 4 child, this is a normal MRI. There is nothing abnormal about it. The third one, information is that this is, so these two are normal MRI. Third one, the information is that this is a preterm child, 29 week, day 3. In term day 4, we looked at the signal changes to identify the myelination because the sulcus and gyri are completely normal. They are well developed. But in a preterm child, what happens is even the sulcus and gyri are pretty smooth. So if we compare this image to the previous ones, so this is a very smooth brain surface, which otherwise would appear abnormal, but otherwise this is a normal appearance at 29 weeks. Now this MRI has just a small abnormality, which is this hyperintense on T1 and hypointense on T2 lesion just next to the optic radiations. But otherwise, this is essentially a normal MRI for a preterm. So these two images are just to show that neonatal MRI can be very difficult to interpret. So there's actually a very good article on the myelination clock, which is very small, and pictorially they tell you how a neonatal MRI looks at different ages, which should always be referred to. So we should not be confident enough in looking at neonatal MRI. We should actually always Google up or read up to see what is normal for that gestational age and then comment on the MRIs. So this is about the neonatal MRI. Now let's come to the HIE pattern. So what are the mechanisms of injury? So mechanisms of injury which can injure the developing brain can be multiple. However, today we are just going to stick to the hypoxia ischemia. That is the only thing that we are going to focus on, because our topic also deals with correlating it with the type of cerebral palsy. So just a quick classification of the cerebral palsy. So this is a very easy classifications which has been proposed because the previous terminologies of quadriparesis, diaparesis, tetraplegia, so these were all very confusing, and different clinicians would interpret these terminologies in different ways. So what they have done is, what they have suggested rather, it is not a universally accepted thing, but this is what has been suggested. So first you classify the cerebral palsy depending on the tone, so the motor component. It can either be spastic, it can either be dyskinetic, it can either be ataxic. Dyskinetic can further be dystonic or chorioathetoid, and spastic as well as dyskinetic you further describe as unilateral or bilateral. And further description is subjective. So I may say that this is a case of spastic, unilateral with upper limb involved more than lower limb, which would otherwise give me an idea that, okay, maybe I'm dealing with hemiparetic cerebral palsy. If I'm saying spastic, bilateral, lower limb involved more than the upper limb, I'm dealing with spastic diaparesis. So this is what the clinical classification of cerebral palsy is. Now, we also have the MRI classification. So MRI classification basically means what? That they have classified the major patterns which are seen in children with cerebral palsy. So this slide looks very scary, but it is actually easy. So there are 5 patterns, of which we are going to deal with type B and type C, because hypoxic ischemic changes usually present with these 2. The first is the maldevelopment, which is already being covered. Second, we have the predominant white matter injury. White matter injury where? Periventricular, which could be because of leukomalacia, or it could be intraventricular hemorrhage or periventricular hemorrhagic infarcts. We have predominant gray matter injury, which is basically basal ganglia, thalamus lesion, cortical, subcortical lesions. And one important thing to note on this MRI classification is that it can also be normal. So we can have a clinical diagnosis of cerebral palsy with a normal MRI. We will look into predominant white matter injury and predominant gray matter injury. So what are the factors which actually determine the pattern of injury? Are just 2. So these are the only 2 things that we have to remember. One is the timing of insult and another is the severity. So by now we know why timing is important. However, just to give a quick idea, after conception, so around this time the brain development starts. So depending on which area of the brain is the most vulnerable and most metabolically active at that particular gestational age determines which area will be injured. So for example, if we have very early insult where just the proliferation, migration, like the basic of brain development has just started. So if we have an early insult, it will lead to maldevelopments. But as we proceed further into the gestational age, as and as the child matures, around preterm age group, we have more of myelination of different areas happening. So that is the time when we have predominantly white matter injury. But for a full-term child, like around 40 weeks, where synaptic formation, dendritic growth, those things are mainly taking part. So there, if we have an insult, it is predominantly a gray matter injury. So with this background information, how timing affects which area will be involved, if we have to correlate the two, that is the clinical diagnosis of cerebral palsy and what pattern of MRI findings are we going to correlate with that particular clinical finding, let me just summarize it in this way. So as per this classification, type B, that is predominant white matter injury, which we saw on the previous slide, happens kind of around 32, 36 week gestation. It usually leads to a spastic form. And this predominant gray matter injury, because it involves all. So it involves deep gray matter, it involves cortical gray matter, it involves the subcortical lesions. So this type C can present in any way possible. So that is why, as far as B is concerned, it is mostly in the spastic group, which typically presents with diaphoretic cerebral palsy. And C can present like any of the three. B is also mentioned in ataxic group, but it is not because of involvement of cerebellum. It is predominantly because these children may also have spastic ataxia. So kind of we know what is the clinical types of cerebral palsy. We have some idea as to depending on what time, what area will be involved. And that leads to the, explains the clinical picture. So now let's see. So suppose, Dr. Pradeep, is my top part of the slide visible?
Yes, it is visible.
Okay,
It
okay.
starts with less than 28 weeks.
Okay, yes. So say looking at the timing, we have a neonate which is born at less than 28 weeks. So what kind of insult are we expecting in this trial? So at this young age, the brain is not immunologically competent enough to generate a reaction and lead to gliosis. So what happens? The brain parenchyma, which is liquefied, doesn't fibrose, but just leaves a defect there, which gets filled with CSF. And because there is no gliosis, so the usual hyperintense signal changes that we expect on T2 and flare, of course, will not happen because there is no reaction only. So how do these early insults present with? So they just present with this enlarged CSF space with just a small part of brain remaining. So this is called hydrancephaly, where there is no gliosis, nothing happening. It was a extensive insult, and this entire space where brain was supposed to be has been replaced by CSF. So this is what happens if the insult is very early. Now let's move further. So we have 28 to 32 weeker. So which area is most vulnerable at this point of time? So that is the subependymal germinal cell area. So I'll tell you, just when I show the images, I'll tell you which is the subependymal germinal cell area. So just adjoining the ventricular margin, just beneath the ventricular margin, we have the subependymal area, where the neuronal proliferation takes place and they start migrating from subependymal area peripherally to form the cortex. So this is the area which is most active right now. And depending on how premature the brain is, more the number of capillaries will be in that area, which are very fragile. So this is the time when any insult will lead to germinal matrix hemorrhage. So here the images that I have shown, first one is a T1 axial, second one is T2 axial, this is T2 coronal, and this is T2 SAG. So what happens? This is like grade 4. This is most severe form of germinal matrix hemorrhage. But where does it actually start? So if you look at this coronal section, just below the, so I'll show it on to the right side. So here is where the caudate nucleus is, just lateral to the lateral ventricle. And here where the thalamus is. And in between the two, you have the caudothalamic groove. So this is the area of the subependymal region which is most vulnerable. So the least severe hemorrhage happens here. Here it is grade 4. So grade 4 means what? There is subependymal hemorrhage which has gone into the ventricle as well as gone to the parenchyma. And it's also causing this hydrocephalus. So because it's kind of important, especially for the exam and mainly from the theoretical point of view for exam purpose. So what is the grading of germinal matrix hemorrhage? So as I said, first is which is just limited to caudothalamic groove, because that is the most vulnerable region. Second is it has gone into ventricle, but not really causing any dilatation. Third is dilated ventricles. And fourth is it has also gone into the hemorrhage. So if you look at these coronal sections, this is the lateral ventricle, the blue shaded part. And just lateral to it is the caudate nucleus. Now, if we look at grade 1 hemorrhage, it is just confined to the caudothalamic groove. The second one goes into the ventricle. Third one is more than 50% into the ventricle and is also causing some ventricular enlargement. And the fourth one, it has gone into the parenchyma, the one which we saw earlier. So this is what happens if it is 28 to 32 week newborn with an injury. Now, what happens if a newborn is at 32 to 36 weeks? So here, depending on whether it is a partial asphyxia or profound asphyxia, the MRI pattern may vary. So as we have already seen earlier, the 32 to 36 weeks is basically the time when the brain is myelinating. So of course, the most vulnerable areas are the ones which are myelinating. We've seen earlier that myelination starts from posterior to anterior. So we have the cerebellum, brainstem. So these are the areas which are myelinating right now. And we also have the myelination of the periventricular white matter tracts, where the lower limb fibers are arranged medially and the optic radiations are also passing through that area. So what happens if you have partial asphyxia? These periventricular white matter region is the one which is most vulnerable, and it leads to, so this is the time when brain can fibrose. So you develop white matter loss, you develop gliosis, and if it is very severe, it can also lead to cavitated lesions. So as the area of insult increases, this insult may also extend to the subcortical white matters. So what happens besides the which area is most metabolically active, another thing that happens is about the watershed zone shifting. So early brain has watershed region which is most medially, right? So it is somewhere just close to periventricular region. But as child goes towards term, this watershed area keeps on moving laterally. So that is why wherever the watershed zone is, even that area is a vulnerable part. So this is what happens in partial asphyxia. Now, if you have profound asphyxia, then the most metabolically active regions get affected, and usually involvement is of thalami, cerebellum, and brainstem. This is a classical periventricular leukomalacia. This is a T2 axial sequence. This is a T2 coronal sequence. What we can see is this is the ventricular lining. And of course, we can see that these gray matter, this is like almost extending quite close to the ventricular lining. There is hardly any white matter left periventricularly. And the second thing that we can find is these periventricular white matter signal changes. Third, these curvilinear appearances of the white matter, of the ventricular margin. So it appears as if this gliosis is literally pulling onto the ventricular margins, which is giving this irregular appearance. So same for this coronal section, that rather than a smooth ventricular margin, we have these pulled appearances of the ventricle. So this suggests that periventricular white matter volume loss has led to these ventriculomegalic appearance. So this is classical of periventricular leukomalacia. And as we discussed already earlier, the lower limb fibers are arranged medially, so they kind of get injured more. So that is why you have the typical diaphoretic kind of a cerebral palsy, that's spastic diaphoresis, preterm delivery, with some birth asphyxia. They usually come to us with diaphoretic cerebral palsy. Now coming to term. At term, what happens? So now the myelination part has been taken care of. The initial subependymal part has been taken care of. For term infants, the watershed zone is more lateral. It is no longer periventricular. It has gone laterally. Plus, now is the region, now is the time when the gray matter starts acting very metabolically active. So again, here, if you have a partial prolonged asphyxia, we can have some white matter changes. We can have watershed zone changes. And this white matter thing and watershed lesions, they occur more posteriorly, because vascular-wise, the anteriorly supplied vascular regions have a strong vascular supply than the posterior. So if there is any compromise, the brain will try to steal water from not so active areas, steal blood from not so active areas and the weaker areas. So mostly the parieto-occipital, temporal, these are the areas which get involved if we have partial prolonged asphyxia. Now, if we have profound asphyxia, on MRI, the thing we look for to say profound asphyxia is involvement of thalamus and putamen. The other things are theoretically described, but just look at thalamus and posterior putamen. So let's see. Here, the first MRI, which is T2, and this is a high, like this is well up cortical section. So we can actually see the cortex, the ventricle hasn't even started. And what we can see is that this parasitally, this peri-Rolandic region signal changes are present. So this is the area which is affected. This is the flare sequence where we can see that similar finding. So this is the area which is like, this is the central sulcus, and we are seeing the involvement around this, the peri-Rolandic region. And here is the classical presentation of a profound asphyxia. So here, these are bilateral thalamus, where we can see this T2 hyperintense signal changes. This is the putamen. So we have globus pallidus inside and we have putamen outside. So this is the posterior putamen where we can see the signal change. So these are classical of term HIE. Now, so term HIE, they usually come with quadri, and as we have seen already, they can come with spasticity, they can come with dyskinesia, or they can come with ataxia. So term HIE can present as either of the three. Now, if it is very severe, so we can have this diffuse atrophy, which we can see in these images. So we have this sulcus and gyri, which are like so prominent. And also we can have cystic encephalomalacia. So I don't have that image here, but so we have different areas which have been replaced by cysts. So there are multiloculated cysts filled with fluid. So they just indicate severe prolonged asphyxia, which can be found either in term or a preterm child, but it has to be profound and for a prolonged period. So this kind of concludes the HIE pattern, but because we are also dealing with cerebral palsy correlates, so I'll just show few common MRI images. So here we have a kernicterus sequelae, which comes with dyskinetic CP, where the classical finding is, so there in term HIE, we saw this part, which was hyperintense. So this is the putamen, posterior part, which was involved. Here, this putamen had spared, but this internal part of the lentiform nucleus, which is the GP, is hyperintense. So it is white as compared to thalamus and putamen. So bilateral, there is GP hyperintensity. So this is the finding that you usually find in children with kernicterus sequelae, required high bilirubin, required exchange transfusion, or maybe the bilirubin was very high, but just went on with phototherapy. So this is the classical MRI image of a kernicterus sequelae. Now, another thing that we find is neonatal hypoglycemic brain injury sequences. So this is also very easy to identify. So this is the cerebellum. We are going up in the MRI. This is where the occipital images start appearing. We can already see that these appear hyperintense. As we go further up, these hyperintensity and volume loss becomes more appreciable. So here again, we can see this volume loss, white matter signal changes, which indicate that there is gliosis, the ventricles are being pulled. So this is basically occipital, and as we go higher up, parietal. And the volume loss is very well appreciable. We can also find some localized cystic changes. So there is parieto-occipital gliosis as well as cystic changes, which is classical of neonatal hypoglycemic brain injury. Because the insult is pretty posterior, they usually do not have much of tonal abnormalities, but what they usually come with is intellectual disability, motor predominant global developmental delay, and they come with visual concerns, because of course occipital is the area where your vision centers are located. So these were the common perinatal, neonatal injury, why it happened and what pattern it comes with. So if we have time, so this is another MRI image of parieto-occipital gliosis, which we can see very clearly, very localized gliosis here. So if we have time, I can share a couple of more MRI images, which are not HI, but otherwise.
Please show few, please.
Yeah, it's just two. So when we looked at that MRI classification of cerebral palsy, besides the point B and point C, which covers the HI, there were also cases of maldevelopment. So like this girl, she presented with global developmental delay. And this is a example of maldevelopment. So what is happening here is the posterior cerebral cortex is fine. There is this division happening. The parieto-occipital are well formed. But what is happening anteriorly is that the frontal lobe is not divided. So what we can see, it is in continuity. So this is basically semilobal holoprosencephaly. So she has this characteristic facial pattern, facial appearance, and she also has microcephaly. Then this child presented with predominantly motor predominant spastic quadriparetic cerebral palsy. And what we can see in this MRI is that the sulcus pattern, it's like very simple. There's hardly any sulcus and gyrations happening. So it is very different from the neonatal MRI of a preterm child that we had seen, because here we can also see the atrophy. So these extraaxial spaces, they are so prominent. The ventricles are dilated. So this is not just simplified brain, which is early in its development, but it is also a atrophied brain. So this is the terminology which is used for these kind of images is microcephaly with simplified gyral pattern, which basically indicates that the insult was very early into the gestation. And these children usually present with good weight. So there was no perinatal insult happening. So that's it. Thank you so much.
Before concluding, Dr. Singh, please show the Ullage idea.
Okay, so I don't have the image of typical Ullage idea here, but if given some time, maybe I can share my screen and show Ullage idea. So Ullage idea basically means, like, if we look at, so this is not very classical, but what happens is that this sulcus, like the part which is black, is the sulcus where the brain is dipping inside. So this base of the sulcus broadens and it appears kind of like a stalk. So you have a thin stalk and you have a mushroom kind of an appearance of the cortex on top. So this is basically what means Ullage idea. This is not a very good image. So maybe I can show here, like if you can see my cursor. So here we have a broad cortex, but the stalk is very thin. And here the sulcus base is enlarged. So this is what oligoidea is.
Show it again.
So this part, actually this is not very classical, but yeah, this part. So the cortex top is broad. This sulcus here is dilated at the bottom and it has a thin stalk. So basically, this base has to be broad. So it kind of gives off a mushroom kind of an appearance. It just indicates that there is atrophy.
Okay. So Pradeep.
Thank you, Dr. Sonali, for your excellent presentation today. That was very lucid also. Actually, we go through development of brain sequentially, how to differentiate newborn MRI from childhood MRI, and also the HI pattern, and when to do MRI. There is no question for this session. Now, I would like to hand over to Sapun sir to conclude the session.
So thank you all our speaker today, like Dr. Naveen, then Dr. Govinda Pramanik, then Dr. Arusi, and also Dr. Sonali. So we are really, West Bengal Academy of Pediatrics is really thankful to you, and also thankful to our participants, though the participant has become thinner today. So I will expect from tomorrow we'll conclude that symposium. So please join in time tomorrow at the same time at 6 a.m. and we'll try to finish it by 8:30. So again, thanks to Pradeep, Porunduti, and Mihir. So good night, everybody. See you.
Tomorrow is exciting session by Dr. Sapun Kumar Rai, Professor Sapun Kumar Rai. So please join.
Okay. Bye. So good night.
Okay, sir.
Good night. Good night.
Good night, sir. With this, we have just completed the neuroimaging session today.
Dr. Pradeep, just one thing. So there is one question that
just
if
one
there
question is there.
Yeah, yeah,
if
yeah.
there is
So,
neonatal insult, what is the ideal time for imaging?
Yeah. So as far as a neonatal insult is concerned, clinically, we know that there is an insult. Early neonatal MRI, the only added advantage is that it helps with the prognostication. So on MRI itself, within 1 month, if you're seeing that the insult evidence is present, it kind of indicates that this child is going to have a bad prognosis. But if you had initial insult, which otherwise normalizes by the time child turns 1 month, it kind of tells us that the child is going to have a good prognosis. But these classical image pattern, which we usually find or which we usually describe, which finally tells us what is the extent of injury is, it is better to do it a little later, once the brain myelination is complete. So a usual time would be like 1 year and up or something like that. Because prior to that, even sedation part and stuff, that is also difficult.
Okay. Thank you. With this, we have just completed our neuroimaging session today. And tomorrow we will go for chest X-ray and USG brain. It will be an excellent session for everyone by Sir Professor Sapun Rai Sir and Dr. Shoguto Chaudhary. Hope all tomorrow in this session.